So the concept of this drug that I've been working with now for several years, and this is the second clinical study that we've done, is that there are rescue therapies that are available for people with epilepsy, such as a nasal preparation of various drugs, benzodiazepines, diazepam, lorazepam. But when you give a drug by a nasal preparation, it has to go across the mucous membrane, it has to get into the bloodstream and get into the brain. And that all takes usually somewhere around 10 minutes. 10 minutes doesn't sound like a lot, but when you're about to have a seizure, 10 minutes is an eternity. So what could we do to shorten that time where people might have a seizure or multiple seizures? So it turns out that there was a company that was working on an inhaler that gets drug not to the mucous membrane of the nose, or there's also rectal preparations for rescue, but to the lung, where you have an enormous quantity of space for the drug to be absorbed. And you can measure the serum concentrations, and even at 2 minutes, there is a very high concentration in the bloodstream and in the brain. So the idea was to see whether that would translate to being able to stop seizure activity in that period of time, because just because you get that drug into the brain by 2 minutes doesn't necessarily mean that seizure activity is going to stop in 2 minutes. So the only way to know is to do a study, and the future goal, of course, is to do a randomized placebo-controlled study. But before going into that, it would be nice to see a few patients who you treat and see what happens. So we decided very early on that we would start with treating 8 to 9 subjects open label, so we knew what they were getting, and see what the consequences were, whether seizures stopped, whether it was reasonable then to go forward with the open label, with the randomized placebo-controlled trial. And so we did those 8 patients, and that's what this poster is about. And I am happy to report that 5 of those 8 patients, all of whom were chosen and then went through a baseline where we confirmed that they had seizure activity that either lasted longer than 3 minutes or that they had multiple seizures within a 2-hour period. So those were the patients, because obviously if you don't have those patients, you're not going to know whether a single seizure is going to be followed by other seizures. So we had a nice prospective baseline where we confirmed that, and then we brought them into the hospital, and the people in the hospital who were watching them knew when this happens, more seizure activity is going to follow. That was the cue to give the subject the inhaler, and they breathed it in, and 5 out of those 8 subjects stopped having seizure activity within 2 minutes and did not have further seizure activity for the 2 hours after that, which is the time that we're trying to protect for. You know, because after 2 hours, they can take an oral preparation or do something else. And interestingly enough, that leaves 3 people who did not respond, and one of them specifically, we noticed that, you know, she was already somewhat in seizure activity, and when she tried to inhale, there was a cloud of smoke that came out of her mouth, and probably she did not inhale it properly. And, you know, we can think that, but we need some evidence to support it. So interestingly enough, it turned out that she and one other person had extremely low levels, because the levels were drawn in the bloodstream. And that may have accounted for the fact that they were non-responders. And the third one had a lower level than, you know, most people. It wasn't as low as the other 2. No drug works for everyone, so we were pretty happy with that, and certainly happy enough with this result that we are going to proceed now with the double-blind placebo-controlled trial, and is already underway. A number of patients have already been enrolled, and we are so excited to see what the result of that is.